This is a patient with a total cataract. This patient has had a previous vitrectomy and is currently posted for a cataract extraction IOL implantation along with a concomitant removal of the silicone oil. Even before the cataract surgeon is to perform the cataract extraction, the retina surgeon will initially create the entry with the 25 gauge trocar, and the importance of doing it at this stage is it is safest to introduce the trocar for a subsequent vitrectomy through that port in a formed eye. This minimizes the damage to the intraocular structures as well as is a lot easier to do when you have a formed globe. So after fixating the globe with the help of a LIMS forceps, the surgeon first marks 4 millimeters beyond the limbus for identifying the point of entry of the trocar. Once that has been achieved, the surgeon then at the 4 millimeter mark introduces the trocar and is now ready to hand the case over to the cataract surgeon. Once this has been achieved, the surgeon now stabilizes the trocar entry and now places the irrigation into the port thus created. The irrigation is just connected, it is not turned on. Once this is done, the cataract surgeon now will proceed with the cataract extraction by phacoemulsification and IOL insertion. The plan is to perform a conventional phacoemulsification. The surgeon tries to grasp the limbus, but please note that there is a significant amount of fibrosis because of the previous peritomy that might have occurred. So get a good hold of the conjunctiva at some point. Then the surgeon performs the 2.8 incision. And then the other incisions. There is significant difficulty in holding on to the limbal conjunctiva, so the surgeon now moves on to using a cotton bud for counter pressure. The other incisions are then taken. Staining of the anterior capsule. Washing out of the excessive dye. Please remember that in these vitrectomized eyes, you've got to be extremely cautious and look for the integrity of the posterior capsule. Look for any signs suggestive of laxity of the zonules. And please note that you're likely to have fairly hard nuclei and a significant fluctuation of the anterior chamber because of the lack of vitreous in the posterior segment. Upon completion of the capsular rhexis, the surgeon now will proceed to hydro dissection. And now we are ready to go ahead with the phacoemulsification. Phacoemulsification is carried out by the direct chop technique. Upon the completion of nuclear emulsification, the surgeon performs a viscofluid exchange. The surgeon proceeds with the posterior capsular polishing. At the end of which, once more the surgeon performs a viscofluid exchange. And please note the dense, thick central posterior capsular opacification. Finally, we get to the last step, which is the insertion of the IOL. By affording counter pressure with the irrigation, the surgeon introduces the IOL. The leading haptic and the optic are in the direction of the bag, and with the help of the irrigation itself, the surgeon has successfully introduced the intraocular lens, and the excess viscoelastic is now washed out with a rocking movement of the IOL. Ensure that you do not overhydrate the wounds, because they reduce the visibility for the retina surgeon when he is going to perform the silicone oil removal. So at the outset now, the infusion is turned on to maintain a nice tight flow. The surgeon will now create the other two ports, which would be used for the introduction of the vitrector as well as the light pipe. The surgeon then proceeds with the silicone oil removal.